it's a real pleasure to be here to share this really groundbreaking work that I know many of you in the room have actually participated in the development of. I don't have very much time to condense 190 pages and 3 years of work into 7 minutes, but I'm going to try. The raison d'etre for this work is to really shift the focus of action from just describing the problems to better understanding the solutions and supporting action to implement them over time. Whilst we focus on solutions, and I was very interested to hear the Gapminder, we have to start with what the reality is. And yes, we've achieved great success for the average. We have 82 years for women and 76.2 years for men in terms of average life expectancy. But that's not the same for everybody. And so, for example, the gap between 1 and 7.4 years for women in terms of how long they live, and up to 15.5 years less for men. If we put this in context, that means that in some parts of our countries, men are dying at 60 and women at 74, just in the bottom 20% income and education groups, just at a time when their counterparts in the top 20% are about to consider retiring, downsizing, making more time for family and cultural activity. It's not just how long we live, but how much the quality of our health is in that life. And the bottom 20% income and education groups within all of our countries are twice as likely to be living with an illness that limits their daily activity compared to if they were in the top 20%. Now, this is significant because those losses mean that those individuals suffer higher risk of social exclusion and poverty. The indirect effects of those people who depend on them financially, emotionally, socially are also compromised. And more broader than that, exiting the labour market early, not participating in society, has implications for fiscal sustainability for the whole of society. So this is why the report is saying health and prosperity are linked, and we cannot have true prosperity that's sustainable where we have health inequalities. So it's okay to describe the problem and the trends, but if we don't know what to do about it, and this has always been the challenge with health equity, then it doesn't take us any further. Here, we've analysed what are the 5 key risks that are holding people back from living a good and a decent life. And we can see that 10% of those gaps that we've been talking about and seeing are to do with lack of quality, affordability, and access to healthcare. Geographically, issues to do with access to trained healthcare professions is also part of this challenge. 35% of the drivers of those inequities is to do with financial insecurity. We have in our mind a picture of those who are most poor in society, but in fact, it's those who are not able to make ends meet, the working poor, those who are doing 2 and 3 jobs and still not able to pay the rent or decide whether they put the heating on or eat at the end of the week. This is a massive shock. 29% are due to living in unsafe housing and underdeveloped and unsafe neighbourhoods. And linked to that is a growing sense of lack of trust, sense of being able to change things for the better and belonging, as well as access to quality education. And decent work, having work, quality work of decent wages and conditions is contributing 7%. What this is really telling us is that the values such as equity, solidarity, well-being and inclusion have really not had a strong position in fiscal and growth decision-making in the last 10 years. And actually, it's not just us as policymakers that are concerned. Reducing inequalities is something that the public are concerned with and the economists and the finance sector are concerned with. So a 50% reduction in gaps in life expectancy would give us between 0.3 and 4.3% GDP increase. The public we have to convince, because politicians will tell us there's no support for making the investment. But the opinion polls tell us that good health is the most important factor about getting ahead in life. And the public are concerned about how inequalities are challenging the solidarity and the stability and peace of our societies. I don't have much time to say much more, but what I'd like to do is to share just one final slide. The Health Equity Status Report is all about solutions. If you go out into the main foyer, you'll see the solutions that we're putting forward and the real lives that we're affecting. We found that the investment in 6 policies can, within 4 years, reduce the gap between the top and the bottom 20% in living with limited illness, within the lifetime of most governments. This is social inclusion policies through social protection investment, 1% GDP, labour market programmes, community facilities and amenities and housing. Reducing out-of-pocket expenditures for healthcare, reducing income inequality and reducing unemployment. These are the 6 macroeconomic factors that will deliver that within 4 years. What that means in a country of 3 million is 10,000 lives saved. In a country of 60 million, it's 250,000 lives saved. In a country of 140 million, it's more than 500,000 lives saved. This shows us that with the right policies, with the right investments, we can achieve change and we can achieve it in the short term. So I'm going to stop there and I'm going to invite our panelists.
Yes,
Pass back to the chair and invite our panelists.
And now I know and I'm sure that you have the skill to finish the panel at 6:15.
He has huge faith in me, doesn't he? So let's see. Okay, it depends how willing our panelists are. Could I ask our panelists, please, to take their seats on the podium? We're just waiting for one final panelist. Okay, it's the Minister of Health of Slovenia. Okay, we don't want any difficult panelists. I'm only joking. Okay. Okay, guys. Minister, please have my chair. Everybody who knows me knows I like to stand up and walk around anyway. That's great. So I get to do the physical activity that our colleagues would like you all to do. Welcome. So we're really lucky today with our panelists to have countries showing us exactly the kind of solutions that they're implementing in real time that are making a difference to real lives. And I'd actually like to come first to Mr. Vaughan Gething, who is the Minister for Health and Social Services from the Welsh Government, United Kingdom. Minister Gething, Prosperity for All is the national strategy for Wales. In it, reducing inequalities and enabling every person to achieve their potential is core. It's quite ambitious and involves dialogue with a whole range of people within and beyond government. Can you tell us how Wales is taking this forward and why you're doing it?
Yes, thank you, Chris. And some of that comes out from the presentation you just made about the cost of health inequity, about the cost from a values point of view, but actually it's a significant economic cost as well. And Wales is a relatively poorer part of the United Kingdom. So if we're going to address health inequalities, we also have to address our economic position as well. So Prosperity for All is the whole government plan for the whole government in Wales. So it's not just a health document, it's for all of us. So there's something about health in all policies, but also all policies in health as well. So I'm just as interested in our economic progress as I am in terms of what we're doing within the service. And again, the slide you had showing the different factors is an important part of that. But the approach is about bringing people with us. So we're looking to do less of doing things to people and more doing things with people. And we have a joint plan for health and social care in Wales, designed together with the government, with the health service, with social care, local authorities, but also housing and the third sector as well. Because if we're going to make the sort of society-wide transformation we want to see, we need more and more partners to feel they're part of it, rather than just having the health service doing things to them. And so when I launched Healthier Wales just over a year ago, it came with that background to it. And I also recognise that to do things at scale and at pace, we need to not just have micro projects, but real and genuine transformation. So it is about actually not just the people and the public, but actually our staff. 90,000 people work for the National Health Service in Wales, and 127,000 people work in social care. So in a country of about 3 million, over 200,000 of our public are actually working in those services directly. They're actually a significant chunk of the public, and they need to be more directly engaged in the conversation about changing, reforming, and improving healthcare. So there's drive and commitment from the government, and that's got to be sustained over a lengthy period of time. But also we have to bring people with us so they make more of their own choices. A better informed public almost always makes better choices.
Thanks, Minister Gething. I would like to come back to you on the second point, because I know key within the Welsh Government is dialogue with those who are being left behind. But because we're short for time, I'm going to take some additional inputs from the panel and then come back to that. So what I'd actually like to do now is I'd like to go to Dr. Boskowski, head of the delegation from North Macedonia. Now, North Macedonia is really investing in scaling up universal health coverage, improving health for all, is really key for Ministry of Health and the government. We know that you see this as the foundations for inclusive and sustainable society, but how are you actually putting this into practice?
Okay, thank you for having me in this panel. I must first thank the regional director for all the support that gift to us in past months. Actually, it was very intensive, and we were working very closely with the WHO. I must say that at the beginning of this year, in February, we started a campaign of remodeling of new primary health care according to Astana Declaration. So it was countrywide dialogue. So every stakeholder were invited to a dialogue and how to put more services and how to reshape, remodel, or re-strengthen the primary health care. Actually, our aim is to bring more services to the people in the primary level, because the data we analyzed so that many people are not accessing well health because of they don't have the services close to their homes, so they have to travel. So one of the idea was to re-strengthen and reshape the primary health care and bring more services to the people close to their homes. Also, what we put, actually, we integrated social services for the first time in the primary healthcare, and we piloted this in one region, and now it's becoming widely in two regions. So we have social services inside the primary healthcare, so they go make outreach with the patronage nurses and also social worker to the more rural areas, and they recognize the medical problems or health issues, so they can advise or they can communicate with the primary healthcare center or GP or family physician to deal with this or to go to a doctor. And also one more thing I want to say, that a very important obstacle that recently was taken off, actually, the access to drugs. So this is a new reform. Actually, now the drugs are widely available throughout the country, so without any bureaucratic obstacle. So every people with a prescription can come and take the drug as long as they need it. And also there is a new e-prescription which will make it easier for people to access drugs in general in the country. So these are the main things according to Access, and I must say this, that vaccination with the help of the WHO and with the strong leadership of the government in 8 months was raised. The coverage was raised significantly. They started with an epidemic of general coverage of 80%, and now we have country coverage of 99% in 8 months. And in the city of Skopje, less than 80% in the capital, which is having like 1/3 of the population. Now is 98%. So with strong leadership, we achieved to put a good vaccination coverage with measles.
Thank you. I'm really sorry to cut our panelists off because, in fact, there is a very rich knowledge and development going on in the country. So I apologise in advance. But what I'd actually like to do now is I'd like to come to our Permanent Secretary Selenauki from Ministry of Social Affairs and Health in Finland. What we've heard from some of our other panelists today is that success depends on putting the social values of equity, solidarity, inclusion into all policies, and particularly into fiscal and growth policies. And Finland has a rich and long history and tradition of health in all policies. How are you putting the social values that we need to make sure that the investments in health equity are taken up? And what kind of experience do you have so far?
Thank you. Of course, data is one big thing that you have to base your decisions on facts, and of course then have discussion on values, and stop thinking that inequality is too complex. Of course, it's multisectoral, and we have to do then a lot of cooperation at the policy level with different ministries, but then also in communities. And if I give you some examples, then a key is a combination of universal coverage and universal services, and then targeted interventions to address specific needs. And there you need really information and disaggregated data to really find the groups that need specific interventions. But it's really important that you have universal service there and universal approach, because then there is no naming and shaming actually. And it's easier then also to do the targeting of different needs then. This is the whole idea in Nordic model in our neighboring countries also. And some other example is then from school system, which is a universal community-based service. And at schools we offer warm school meals daily. Then there is also exercise for everyone, and education, also how to read the information and be critical with reading information, but also information on healthy lives. Then you ask about the social evidence and actually well-being. We have a long time had integrated social and health services, but also integrated social and health in our ministry also, and trying to then combine those two different languages and cultures. And I really recommend that. And now during our EU presidency, we are introducing a new definition, actually, on new policy and mindset change, like economy of well-being. And I already now thank all the member states in the EU for your positive contribution to those council conclusions we are preparing, you will find out there then some steps that we are agreeing on how we can then proceed with this, seeing really that when you have well-being at the core in policy making at the country level, then you can see really the impact of well-being of economy, sustainable economy and sustainable societies, and that is country specific, not some ideal model.
Thank you very much. That picks up some threads across the panelists in terms of needing good disaggregated data. So the Gapminder, we love the concept. Let's get some disaggregated data in there, please. And also picking up the need to build alliances within and outside of government, but that when we design our policies, we need to understand the reality of the lives of those who are falling behind, because they're not normally reflected in the way our policies are designed or evaluated. So these are some of the themes. And I'd like now to come to a country who, again, we would like to thank, in addition to the chair, Slovenia, the Minister of Health, Alice Šabeder from Slovenia, Minister of Health. You hosted the high-level conference on accelerating progress for equity in health in Ljubljana. And we know that this is a reflection of the long-time commitment to tackling inequalities, not just in your own country, but actually in neighboring countries and in the region. Can you share with us some of the things that you're doing in Slovenia to take this forward currently?
Yes, thank you. Slovenia is traditionally providing universal health care coverage for all the citizens, and yes, we have recognized a focus on reducing inequalities in health. Health as well as equity has always been one of the most important values in our society. This, for example, is also reflected in development policy of Slovenia by 2030, where healthy and active life has been identified as the first development goal by the national parliament. Furthermore, in the National Health Plan, Together for Health and inequalities in health are recognized as one of the key challenges for the future in our country. In health, we are already convinced that only through comprehensive approach and partnership with other sectors and stakeholders, let's say, we can successfully address these challenges. On the other hand, we are confronted, and I believe this is the case in all our countries, with rising health needs and expectation for our people and our citizens.
Thank you very much. We'll come back if we get a chance for any other questions. You mentioned the need for new partnerships and new alliances. So what I'd actually like to do now is to come to a very good friend and colleague of mine, Mr. Jan Peluza, who's from the International Youth Health Organization. I think there was a mistake in the program. We can see from the Health Equity Status Report, Mr. Peluza, that 18 to 28-year-olds are the most at risk and a new at-risk group for health inequalities. This is an epidemic waiting to happen that we can do something about now if we choose to. Jan, how can we develop alliances with organizations like yours to ensure that the voice of those who are at risk is really taken up into mainstream policy? Jan.
Thank you very much. Thank you very much for this opportunity to be speaking here on behalf of different youth organizations working on health and that should be working on health around Europe. A very important thing nowadays is to understand that after the 1990s, there's a lot of things being outsourced from the governments. And especially where I come from Slovenia, I can say that, thank God, it went towards the NGOs and not, for example, towards industries doing health education in schools. But what is very important here is that the non-governmental organizations, in my point of view, and point of view of some people in the sector and outside the sector, we see ourselves as a glue, connecting different stakeholders. While unfortunately, from the other side, many times we are seen as activists only, or, for example, the first responders when it comes to specific action. Now, I understand, and I've been working in this sector for 15 years, and I can say that it's clearly a lack of trust, but at the same time, we shouldn't forget that the non-governmental organizations are in the public interest. In my point of view, if well coordinated, we believe that two horses can together pull a greater weight than two individual horses. And imagine if you would be able to coordinate 27,000 NGOs from Slovenia. So since I was asked about some clear suggestions, I asked my colleagues in the sector and say, if you had an option to talk to health ministers, what would you suggest? And there are three things that came up. One thing is that make sure you understand how NGOs work. There are many of you who understand it perfectly, and this is, in my point of view, a great starting point. Maybe take a champion out of the NGO sector and employ it on the ministry or in the National Public Health Institute and say, how can we work more with NGOs? The second one, increase funding, which is clear, everybody's asking that, but also without increased funding, especially include NGOs in different processes so we understand exactly what is it about. If we want to be a glue, we need to understand, and we shouldn't be giving wrong answers at the end of the day with lack of information. So believe me, lack of information brings to wrong decisions, and lack of money brings into fighting in the sector. And we don't want to have a sector that is fighting. And last but not least, evaluate, evaluate, and evaluate. I don't reject the right, or let's put it this way, don't make it right away somebody who is not that effective, an NGO that's not that effective, or it's even harmful, and not giving money anymore. This is the worst thing to do. You need to bring together these organizations and teach them how to make things work better. Even better, on the long term, these organizations and ourselves, between ourselves, we will self-regulate. When the lights go off, this is just my last thought, when lights go off and someone is left with a hand in the jar of cookies, believe me, this person will feel bad by him or herself anyway. So definitely the NGOs should be taken as equal partners, and I'm definitely here also to give a help to maybe establish this in the future.
Thanks, Jan. And I think the fact that you have the reach to the risk groups is really an advantage. But what you're saying is work with us, give us the information, trust us. Okay, good messages. Michael, I'm going to ask you to do something that might be completely impossible. Can you, in 2 minutes, tell us why the issue of reducing inequalities is really something that the medical and health professions really need to take centrally in how they work? And you've got 2 minutes, and the chair is going to time you.
Well, you know it's a trick question because the WHO Commission on Social Determinants of Health said the key determinants of health lie outside the healthcare system. It's not what doctors do for patients. And the contradiction is that the World Health Organization is governed by ministers of health. And yet we're saying that it's agents across society that are responsible for health and health inequities. And I'm going to answer a different question first, but I'll come back to it. And the first question that I want to answer is anyone listening? And the answer is yes. Susanna Jakob set up a review, a European review of social determinants and the health divide. And as you heard from Susanna this morning, is fundamental, addressing social determinants of health. Dr. Tedros has set up a new division in Geneva on healthier populations. The third, actually, many of us think it's the first division, healthier populations. PAHO said, if Euro can do it, we can do it. So there's a PAHO commission, which will be published on the 1st of October. The Eastern Mediterranean Regional Office is now launching a commission. And so then your question is, where do doctors and nurses and health professionals fit in? Where do ministries of health fit in? There was an editorial in the Wall Street Journal last week from a select medical school in the US, and the writer was horrified. Medical students are being taught about social justice. Medical students are being taught about climate change. They've got to go back to their real business of treating patients. We said social injustice is killing on a grand scale, and doctors are absolutely fundamental in that. And we said there are 5 things that medical associations, Ministry of Health, doctors can do. First, education and training. Second, seeing the patient in broader perspective. You don't treat homeless people's pneumonia and drug problems and send them back onto the street. Makes no sense. Third, the health system as employer and impact on the community. Fourth, working in partnership. And fifth, advocacy. And we said in our PAHO Commission report, I quoted an African, Nelson Mandela. Overcoming poverty is not a gesture of charity. It's an act of justice. It is the protection of fundamental human rights, the right to dignity and a decent life. And that's what the health professions are working at every day of their lives.